Good morning to everyone and welcome to our Guide to Feasibility and Pilot Implementation Trials webinar. Before we begin, I'd like to acknowledge the traditional custodians of the land on which we're all meeting today, pay my respects to elders past, present and emerging, and acknowledge any Aboriginal and Torres Strait Islander peoples who might be joining us today. My name is Ben Smith. I'm the Co-Deputy Director of the Centre for Oncology Education and Research Translation, also the Chair of the Implementation Science Community Practice, and I'll be moderating today's webinar. Today's webinar is brought to you by the Cancer Implementation Science and Sydney Health Partners Implementation Science Community of Practice. And the Cancer Implementation Science Community of Practice works with the Translational Cancer Research Centres to try and build implementation science capacity and collaboration to achieve better cancer outcomes. And we really aim to provide a forum for people to collaborate on translation of best evidence into care and to develop a rigorous research program to try and improve the uptake of that evidence into practice. We'd like to thank Cancer Institute New South Wales for their support of this program. Similarly, the Sydney Health Partners Implementation Science Community Practice is a community for all those interested in implementation science. Is not cancer focused, as with the previous organisation I talked about. And it aims to bring together health professionals, researchers and students from across Sydney Health Partners and beyond to share knowledge and networking to deliver initiatives and methods to improve the translation of evidence into clinical practice. And they also offer capacity development through annual education and training events and workshops and some pilot grants, which I believe Susanna might have been the recipient of one of those. And just to give you a brief overview of what the program looks like today, we're going to have, I'll introduce our speakers in more detail as we go, but going to get an overview of feasibility and pilot studies for implementation trials and a project case study from Associate Professor Joanne Shaw, followed by some Q&A. We'll have a 5-minute break around 11:50, followed by another couple of case studies with Q&A after each and a more general discussion at the end. We really encourage people to ask as many questions as they wish, and we'd ask that you use the Q&A function on Zoom rather than the chat function. That just helps us keep track of those questions. But really want you to make the most of the expertise and experience we have online today and ask as many questions as you like. And for those who are interested in playing along on social media or Twitter specifically, if you want to use the hashtag ImpSciFit, that will help us collate, I guess, all the info from today's session. So I've got a fantastic lineup of speakers today who I'll introduce as their presentations begin. But our first speaker is Associate Professor Joanne Shaw, who's the Psycho-Oncology Cooperative Research Group, or POCOG, Executive Director and a Senior Research Fellow at the School of Psychology, University of Sydney. Jo's a very experienced psycho-oncology and health services researcher who's got a specific interest in development and evaluation of psychological and supportive care interventions to improve outcomes for people affected by cancer, and also models of care to ensure that those interventions are effectively and efficiently delivered. Jo is one of the authors of the Australian Clinical Pathway for Identifying and Managing Anxiety and Depression in Adult Cancer Patients, and a chief investigator on a Cancer Institute New South Wales translational program grant to implement those pathways in 12 cancer services across New South Wales. And we're delighted to hear more about that program of work today. Thanks so much, Jo. I'll just stop sharing now.
Okay, just give me a sec and I will share my slides. Okay, thanks, Ben. So today I'm going to talk about feasibility and pilot studies for implementation trials, really focusing on how not to end up with lost in translation. And the reason why we're focusing on feasibility and pilot studies really comes down to the fact that health service research has really burgeoned in the last 15 years but it's not always been implemented, and the findings haven't always been implemented and are not sustained in the longer term. So what we're finding is that the interventions that we're developing really are not leading to the desired real-world practice change.
Joe, just sorry to interrupt.
Yep.
I can't see your slides. I'm not sure if that's...
let me just check that.
Shared correctly.
Let me just go back. Try sharing again. Can you see them now?
Yes.
Okay.
Yeah, perfect. Thank you.
Okay. All right. Let me just move this. Okay. So, as I was saying, health service research really, the interventions are not often leading to the desired real-world change. And this means that something like 30 to 40% of patients are not receiving evidence-based care, and the interventions that we're developing are taking up to 17 years on average to actually result in practice change. And there's huge waste in research funding. We've seen this rapid increase in implementation trials, but the quality of these trials has been criticised, and the impact even in implementation research has been modest. And so there's been a lot of discussion about why this is potentially the case. And it's been posited that what's happening is people are jumping too early to implementation studies, and there's less attention being paid to the feasibility and the piloting of implementation research. So what do we mean by feasibility and pilot studies? If we think about intervention research, there are three key questions. Feasibility is about, does the intervention, can the intervention work? You know, are patients and clinicians willing to participate? What sort of outcomes should be targeted? And are the intervention components acceptable? We sometimes look at barriers to the use of the intervention. In a pilot study, pilot studies are really sub-studies of feasibility, but they have a specific purpose. They're to explore, does it work? It's really feasibility and acceptability of the intervention and the methods that we want to use to test in a large RCT. Intervention research is very individual, patient or clinician focused. But these three questions also can be asked in implementation research. So in implementation feasibility, we're not just asking, can something work, but we're asking, if it's so, what context? So what we're trying to develop in feasibility studies from an implementation research perspective are the strategies that will actually facilitate the intervention being implemented. Often we actually have to develop the implementation strategies as part of feasibility, but sometimes we actually use evidence from previous similar implementation research, and we're interested in assessing whether the potential implementation strategies that we hypothesize might work actually will have any impact. So we're looking at, again, at whether or not implementation strategies are going to work in a real world context. We're also looking at, more generally, the feasibility of the implementation methods that we're interested in using. Similarly, for pilot studies in an implementation research perspective, we're really asking, what do we need to do to make it work? So we're not just looking at how do we implement the intervention, but we're testing in a rigorous way whether or not our implementation strategies will actually facilitate the trial. So we're testing the overall trial design. We're testing the intervention and whether the intervention is feasible, but we're also testing whether the implementation strategies that we propose to use in that trial are feasible as well. Are they going to work? How are we going to measure them? are our outcomes feasible from an implementation perspective? And all of this really builds to those large-scale programs of work where we have system-wide implementation, where we're testing whether or not our intervention and the strategies that we've developed will work in real-world settings. So we're really building up to demonstrating through feasibility and pilot work that we are able to make system-wide change. So when we think about feasibility designs, we still use many of the designs that we use for intervention research. We often use qualitative methodologies and cross-sectional designs. So, you know, a common feasibility study from an implementation perspective is a barriers and enablers analysis. I think the difference is that we're not interested in whether or not the intervention itself is going to, if the barriers to the intervention, we're interested in the barriers and enablers to implementing the intervention. So often we're interested in determining the acceptability of not just the intervention, but the strategies to make it happen, the feasibility of how we're actually going to test the intervention in health services, and also the appropriateness of the strategies. We're very much interested in the context in which we're implementing, and we're looking at whether or not the complexity of the system influences how the intervention needs to be approached from an implementation perspective. I think that there's quite a lot of buzz at the moment around hybrid designs. And I think, you know, there's been lots of questions across implementation communities of practice and implementation groups about, oh, should we be doing hybrid designs? And a lot of people don't really know what they are. So from a feasibility perspective, a hybrid design, a hybrid one design, is really looking at incorporating implementation outcomes into your efficacy study. So you're nesting outcomes for implementation in an efficacy study. So your main aim is the intervention effective, but you want to observe how the intervention is implemented in a real world setting. And so the outcomes of hybrid designs are informing the feasibility of the intervention, and also what sorts of implementation strategies you need to consider moving into the implementation research phase. Similarly, for pilot studies, we've already identified what we hypothesize are the implementation strategies. And so in a pilot study, we're interested in whether or not the mechanisms of these hypothesized strategies are actually going to be feasible. We're looking at both implementation strategies and the trial processes, and we're often replicating the trial methodology that we're going to use in our main implementation trial to see whether everything fits together. So does the intervention work? Can we actually implement it? Are our trial processes and our outcome measures feasible? And this is where the hybrid 2 designs come into play. And in a pilot study, when you're using a hybrid design, you're actually testing whether both the clinical intervention and the implementation strategies that you have identified as part of your trial are going to work. Are they feasible? You're measuring the impact of the implementation strategies on the implementation outcomes. And often what you do is you run your pilot study and you include all of the measures, the implementation measures and the outcome measures that you're going to use in your main design. But what you also do is you include a sub-study, which is typically qualitative, to assess the stakeholder experience. So you get feedback on how the strategies worked, what was effective, what wasn't effective, what other strategies potentially you may not have thought of that would have been helpful to implement whatever the particular clinical intervention is. So the design of pilot studies really is aiming to assess what are the barriers and enablers to the delivery of the strategies. What factors influence the use of the intervention? Was the entire intervention and implementation strategies acceptable and feasible and appropriate? Did you need to adapt your implementation strategies or your intervention to make it feasible? And what was the reach of your intervention and your implementation? Did you get engagement from the health service? Did you only get engagement from some of the health service? And that gives you an opportunity to think about, what do I need to change before I go into a real, into the larger scale study? You're also interested in factors influencing fidelity to the implementation. So are some of your strategies that you've developed just not feasible and there's a drift over time? So people may be very keen at the beginning, say for instance, training, they may be really keen to do training, but over time, as new people come on board, training sort of drifts away. People are not undertaking it. And so what you're trying to do is just generate preliminary evidence that your hypothesized strategies and the mechanisms about how you're going to implement something actually do translate from research and a very contained environment into the larger real-world health service. And I think it's really critical to remember that we need to think about implementation and the outcomes of implementation and implementation success in terms of both success for the intervention, but also success from the implementation. And I think this is where we've fallen down in the past, and we really need to separate out our thinking in terms of intervention and implementation. And we need to think about piloting and feasibility in terms of not just, is our intervention feasible, and think about how we implement it. Is the methodology for implementation also feasible in a real world setting? And I think the other thing that we need to be really clear about is definitions. So we need to think about the strategies, implementation strategies, you know, the methods and techniques used to enhance adoption and implementation, sustainability. And then we need to think about outcomes. And this is really important for pilot studies. We need to have measurable outcomes. We need to know what the process or quality measures are and how we're going to assess them. And that's something that you can really explore in pilot studies. You know, are we going to use evidence-based questionnaires? Are we going to use composite measures of health service outcomes? We need to define and make sure that we actually can access the data to measure outcome. And that's something that you can explore in a pilot study without impacting on the outcomes of your larger program of work. So that's all the theory. I'm just going to spend a few minutes talking about some feasibility and pilot work that we did prior to implementing the Australian Clinical Pathway for Screening and Assessment of Anxiety and Depression in Cancer Patients across 12 cancer services in New South Wales. So we had a large program grant to develop and implement the clinical pathway over a 5-year period. But today I'm only going to focus on what we did for feasibility and pilot work. So just a bit of a background. So anxiety and depression are high in cancer populations. There's really robust evidence to demonstrate that approximately 1/3 of patients experience clinical levels of anxiety and depression. And this is not just feeling a bit distressed or a bit down. This is serious medical concerns. We know that untreated or undertreated, these disorders carry substantial costs in terms of adherence to cancer treatments, intensity of side effects, poorer quality of life, increased health service use. For depression in particular, major depression increases the likelihood of suicidal ideation, and also cancer patients are actually 4 times likely to commit suicide than the general population. And cancer survival actually is also poorer for those with major depressive episodes. We also know that there is a whole range of psychological and pharmacological treatments that have been demonstrated to be effective. However, uptake of services is low. So there's large cohort studies internationally demonstrating that less than 50% of patients with clinical levels of anxiety and depression access psychological treatment. There's also evidence that there's gaps in referral. So less than 25% of people with anxiety and depression are actually referred for treatment. And 9% of those cancer patients with really serious mental health conditions are referred within the first 3 months of their diagnosis. So not only are people not being referred, when they are referred, there's delays in referral and treatment. This poor uptake can only partly be explained by patients' denial of their emotional problems or hesitancy about taking up mental health interventions. We know that from a health service perspective, clinicians often just don't detect anxiety and depression, or the severity of symptoms are underestimated. People think it's just part of having cancer. Less than 30% of oncology health professionals can actually identify anxiety and depression symptoms in their patients. And in contrast to physical symptoms, patients are just not asked about it. And so few patients volunteer information during the consultation because they think that, well, if they're not asked, it's not important to their treating clinicians. So there's international evidence that routine screening of patients with cancer for anxiety and depression is recommended. But what actually happens in practice is screening's not routinely conducted in Australia. And why people don't screen is there's a lack of confidence, there's insufficient training around screening and referral, time pressures, and there's a perception that there's a lack of psychosocial staff and referral guidance once somebody's identified through screening. So POCOG developed a clinical pathway to guide clinicians in oncology around anxiety and depression. It's an evidence-based pathway that incorporates screening for identification of anxiety and depression, and also provides clear management strategies for what to do next. It's flexible and can be tailored to individual cancer services. It provides timings for follow-up, and it details the roles and responsibilities, and it uses a step care model to guide care. So there's clear treatment options based on severity. And the benefit of the model is that it can be flexibly tailored to the local referral networks within cancer services. So our question really was, how can we get this pathway into routine practice in Australia? So we undertook some feasibility work right at the very beginning, before we even got funding to implement the pathway. We undertook a process of stakeholder involvement designed to ensure that we had engagement from clinicians. We wanted to gain multidisciplinary perspectives about whether or not the pathway was acceptable for all healthcare groups within cancer services. And our aim was to explore what were the most significant barriers and enablers to implementing the pathway into Australian cancer services. So we undertook a feasibility study to seek expert opinion from 12 multidisciplinary clinicians and we used standard qualitative methodologies. And what we found was in our thematic analysis that there were really 5 overarching themes that influenced whether or not cancer clinicians would implement the pathway. And these themes covered, ownership of the pathway. So was it locally seen as valuable, roles and responsibility and resources. There was concerns around patient reluctance. Similarly to what we've seen from other international research, there was concerns around education and training within cancer services. And this concern around how once people had been identified, how there was integration with other health services, so psycho-oncology and mental health services. So this really broke down to, on the ground, concerns around cancer services leadership and staff. Was there going to be institutional support and local ownership? How was time going to be managed if we implemented this pathway? And the need for education and training. There was recognition that there's just not enough psycho-oncology staff to treat huge numbers of patients that would be potentially identified. And even though patients may be identified as having anxiety and depression, there was still this perception, there was a reluctance to take up the intervention. So there was a concern like services could put all of this work into screening and then patients weren't interested. So based on the feedback from our initial feasibility study, we developed a whole lot of resources to support the implementation of the pathway. So we developed and piloted implementation resources around providing patients with resources to explain what screening was and normalising anxiety and depression. To educate health professionals, we developed an online education program that walked people through the whole process of screening and referral and gave really clear modules on how do you actually discuss screening, how do you make a referral. To adapt to address the concerns around lack of psycho-oncology workforce, we developed an online program that patients could be referred to if they were unwilling or unable to access face-to-face mental health treatment. And we also developed a portal that operationalised the pathway that was aimed at trying to provide a strategy to manage and contain the time that it took to document all of the screening results and then all of the referral pathways that can be tailored locally. So the portal actually took away the need for the cancer services to do paper screening and enter results. So we operationalised and systemised the actual screening. We systemised a series of alerts. So the health services were notified when somebody screened high or there was a concern around mental health concerns. And then we actually tailored the referral pathways to the local services. And so when they entered the portal and looked at screening scores, they knew who and where they needed to refer people to. So that limited the time and actually gave a consistent localised referral pathway.
5 minutes ago, Jo.
Great, thanks. So what did we do next was then we used the Paris framework to influence the implementation strategies that we used to implement both the pathway and the intervention resources. So we used a systematic review and the literature to identify common implementation strategies that would facilitate the intervention and the associated resources into our major implementation program. And these are the common strategies that you see across implementation: awareness campaigns and champions, education, academic detailing, and of course the ADAPT portal. We then piloted our intervention and our implementation strategies in a single health service, a cancer service in New South Wales. And we used the protocol that we were planning to use to see whether or not it all actually hung together. So at the service, we held a series of engagement meetings over 3 months. We tested out our survey and interview, our baseline data for survey and interview. We implemented the pathway, including the portal. And then we used all of the implementation strategies to support the service over a 5-month period. And again, assessed the outcomes at 6 months using survey and interview data. So the aim of this was really to test the feasibility and acceptability of the method of implementation that we proposed to use in our major trial to refine the implementation strategies that we were going to use. So we tested the components of the overall intervention. We observed the process. We identified local issues and barriers that may actually have implications more broadly. And we developed processes to make the implementation much smoother in the longer term. And we also elicited feedback from real-world frontline users so we could integrate their experience into the wider trial. We also looked at both quantitative and qualitative data. And what I'm going to talk about just in the last few minutes is the qualitative data, so the service experience and how we changed our protocol based on this feedback. So we conducted qualitative interviews, we used standard interview methodology, and we identified 8 themes. And it really, we contextualized them in terms of the Paris framework around evidence, content, and facilitation. And so, we got feedback on staff perceptions of ADAPT and the local need for it. We explored how the culture influenced the implementation, any external influences. We also looked at intervention fit, the need for ongoing training, how we engaged, and the burden from a health service perspective. And we found that we did need to modify the implementation process. So we thought we had the perfect trial design, but based on the feedback, we identified really what we needed to do. We really needed to have more on the ground support. We thought we'd done all the training, but we actually identified that we needed to have the staff there full-time assisting during the first couple of weeks of the implementation project. We needed to really tailor the training that we were giving around the implementation of the pathway. We needed to actually engage every member of the healthcare team in the workflow that was proposed so they could see how their roles interacted with the bigger picture. We also realized that it doesn't matter how many training manuals you have, people actually need quite a few goes before it becomes routine practice. And we developed a train the trainer model to allow new staff to be able to train using local resources because staff turnover is inevitable. So really, this influenced how we approached our larger trial. And if you want more detail about exactly how we've done all of this, we've got 3 publications that now detail both all of the in-depth feasibility and the 2 papers that outline our pilot studies. But really what it comes down to is that when you're thinking about implementation and piloting and feasibility, you really need to draw the evidence from both the research base and the local expertise and clinical knowledge before you embark on an implementation program. You really need to understand the local context and the service and the cultures and the values and how that's going to impact on your main trial design. And think about facilitation. How is it actually going to work in a busy health service? And you need to test that out before launching into a major implementation program of work. So pilot and feasibility testing can provide really important early insights that assist in improving the successful full-scale implementation. So in closing, I'd just like to also highlight that these programs of work require big teams. So I'd like to acknowledge all of the members of the ADAPT team. Everyone has contributed their expertise over and above what was expected, and we're very, very grateful. And also we'd like to acknowledge our funders. So this was funded through Sydney Catalyst funding for our feasibility and pilot work, and the translational program grant from the Cancer Institute for the main implementation program. And POCOG is funded by Cancer Australia as one of the Cancer Australia clinical trials groups. So thank you. And I'm not sure about timing, but I'm happy to answer any questions.
Bang on time, Jo. Thank you so much. Yeah. Perfect. And we've got a few questions in the Q&A function already. Just a reminder to please put them in the Q&A rather than the chat. It just helps us keep track of them. But yeah, thanks for a great presentation, Jo. There's some interesting questions here. The first one is from Mona Farris, who asks if during the kind of initial pilot or feasibility work, it becomes clear that certain implementation strategies would be useful, would you then need to run a second pilot to actually test their feasibility or acceptability in the same context, or a different one, or is it okay just to go ahead and implement them in the larger trial? Do you think, like, what? Yeah, when is enough energy?
When's enough?
Yeah.
Oh, that's given that Mona has been working with us on the ADAPT program. I think that's an unfair question. No, it's actually a very good question, and I think it comes down to a pragmatic decision. So if you're talking about tweaking your implementation strategies, I think it's probably a pragmatic decision to think about going back to your pilot site and talking to them and getting their feedback, and then implementing them into the wider trial and assessing very early on whether or not you need to adapt them. Now, I think, if you're thinking about, in terms of pure trial design, you would say, yes, you'd run a second pilot study. But the reality is there's just no funding for that. So if you're tweaking and you're just refining, I think just getting feedback from end users in the pilot study is a rational approach. If you found that your strategies just didn't work at all, you've just missed the mark completely, then I think you probably do need to go back and retest. Mm-hmm. So that would be how I think it's a pragmatic decision in a lot of cases. Yeah.
And there's actually someone else, Rayan Salamusa, has come up with an interesting suggestion that, and I'd be interested to hear your thoughts on where you could perhaps do an interim analysis in your pilot and then adapt implementation strategies, perhaps a latter part of the pilot. What do you think about that idea?
Look, I think what you could possibly do is, I think it's a valid suggestion. I think that if you build that into your research design up front, and you think carefully about what the triggers are for that interim analysis and how you're going to assess outcomes, you may well be able to do that. So it may be you consider this as a sort of a co-development exercise with the health service. So you could potentially, you know, upfront agree that you're going to implement, these are the implementation strategies that you're proposing, and then you get their feedback, and again, you tailor it to the local the local conditions and the local context and reassess. So, you know, I think, yes, that's probably an interesting strategy to use, but you would actually need to think to have that built into your design and make sure that you have sufficient sample to be able to do that.
Okay, great. Right, they're coming through thick and fast now. Just letting people know you can upvote questions if there's questions there that you really want to hear answered. If we don't get through all of these now, we will, as I mentioned, have a more general discussion at the end of today's session. But there's an interesting one here from Zoe McHugh, who says, in terms of scaling up interventions across a number of different LHDs, does the pilot study work relating to one site really tell you or give you enough information about implementation strategies that might work in other contexts?
Yeah, really good question. And my short answer would be no. I think local context is everything. However, what you can gain from a pilot study in a single site is work out what level of engagement prior to implementation you need to identify what that local context is and how best to adapt your strategies to fit context. So I agree that you know, if you could pilot in a number of sites, it's probably from a methodology perspective, it's probably a more robust methodology. But when we're talking about health services research, we're actually talking about a limited number of health services that you can. So you don't want to use all of your services or, you know, a large number of your services in your pilot work, because then that impacts on the number of services you can use in your larger main trial.
Mm-hmm. Right. So a couple of people have upvoted questions. I'll try and address maybe some of the ones that are more specific to ADAPT and leave some of the more general ones for later. But one person has asked, like, or wondering if the ADAPT portal was used in a context where electronic medical records were already being used. And I guess, did that impact on your selection of kind of pilot sites or feasibility analysis in any way?
Yeah, look, I think that's again a really interesting question. So when we initially designed the portal and our initial funding, we aimed to integrate the portal into electronic medical records. And what we realised very early on, both in feasibility and piloting and also in engagement with the sites very early on, prior to our main trial, is that there were so many different medical records and variations of the same systems that it was not feasible. And that is one of the downsides, I think, to the ADAPT portal, was that it's not integrated, and it did impact implementation. It did impact sustainability and to some extent feasibility. But again, it ends up being the balance between real world experience and what's happening on the ground and limitations of research time and funding.
Yeah. That's a tough balance to find sometimes. So Kristen Davies has asked, what strategies do you use to ensure high impact publications of feasibility and pilot studies? Any tips there?
Sure. I think that, yeah, I have to say that we did have trouble publishing one of our portal papers because it was considered very, it was a one service. I do think that really targeting journals that are focused on implementation and really being able in your publication to demonstrate that you've used theoretical and implementation frameworks to develop strategies, and really the trial designs that you're talking about are all based on known frameworks. I think that gone are the days where you can just run a small study and try and publish it without having a really strong implementation science framework around it. So I don't know if that answered the question, because I think we all struggle with trying to find high impact journals that will publish our research. But I think that it's really about the quality of the implementation science that's going to drive the publication in higher impact journals.
And was there a particular framework that guided your work that you found useful?
Oh, did I? Sorry, I must have just skipped over that. So when we were looking at sort of an underlying model, we used the Paris framework. But when we were looking at defining our implementation outcomes and based on our strategies, we used the Proctor outcomes. And we actually, and there is another paper called that Heather Shepherd was lead author on, where we actually defined each of our outcomes using the Proctor definitions, and we used those as a way of operationalizing our outcome measures.
Okay, well, that could be I think it's something that a lot of people struggle with, operationalizing some of the implementation outcomes. So,
and I'm really sorry, I feel embarrassed. I can't remember the name of the paper that Heather was the first author on, but I will send it and we can put it out, because it really is a very good explanation of how to operationalize these, what can be quite nebulous implementation terms.
Great. So we'll send out some resources, people, after this webinar, including that paper. There's also a useful table in the paper that was kind of set as pre-reading, I guess, for this webinar, if people are interested. So we'll reattach that to the email that goes out after this. I think we've got time for one last question, maybe one from Isaac Addo, who says, should the participant characteristics for the pilot study be the same as the main study? And I have something kind of following on from that. When you're engaging with healthcare professionals, how do you prevent only having the people who are really keen and supportive of your intervention that you're implementing, engaging and giving you, I guess, a slightly warped perspective of what the likely barriers and enablers might be?
I'll answer the second part first. I think that when you're first approaching people, yes, I think you'll often get those that are engaged. But when you're talking about practice change, I think that you do get, and we definitely got it in our pilot study, people who were less enthusiastic and who were challenged by changing workflows or change in practice. There was a lot of feedback from our pilot site that we already do this. And in actual fact, we probably ended up getting more feedback from those that were less engaged than those that were really engaged. So yeah, it's when you're putting a whole of service implementation project in place, I think that you can often engage with those that have problems with it quite easily, because they want to tell you why it doesn't work, which is really great for a pilot study. because it gives you, so that's why engagement and context were really important for us. And then I guess the first question around patient characteristics, I think you really want to consider how applicable the intervention and the implementation is across a service. So if you're being very targeted to one patient group, then you probably just need to access that group and see how that clinic actually that tumour stream or that clinic operates. But if you're trying for broad applicability, then yes, I think that you need to have your patient group and as well as your health service group, you need to have a broad representation across the service.
Yeah, okay. Well, there's about 10 questions we haven't answered yet, but we'll try and get to those in the Q&A at the end of the webinar. Just highlighting for some people that Nicole Rankins put in the comments that the paper that Joe couldn't think of is called The Elusive Search for Success. It's published in Frontiers Public Health, and she's given a link there.
Thank you, Nicole.
So we're going to have a 5-minute break now, just so people can grab a cup of tea, go to the toilet, have a quick stretch. So thanks so much to Joe for a great presentation, but make sure you don't go anywhere, because next up we have Associate Professor Susanna Park and Peter Grimison talking about their feasibility implementation trial addressing chemotherapy-induced peripheral neuropathy. So see you all back at, let's say, 11:57. Yeah, catch you then. Okay, well, welcome back, everybody. I'll now introduce to you our next couple of speakers. Welcome back. As I mentioned, that's going to be Associate Professor Susanna Park and Associate Professor Peter Grimison, who are talking about improving screening for chemotherapy-induced peripheral neurotoxicity feasibility study. And Susanna Park is an NHMRC RD Wright Biomedical Research Career Development Fellow and Associate Professor in Neuroscience at the Brain and Mind Centre, University of Sydney. Associate Professor Park is a leader in chemotherapy-induced peripheral neurotoxicity research and has been awarded competitive research funding in projects across clinical neurosciences. She's been working at the interface of clinical neuroscience and oncology for the last 15 years and has led several studies examining clinical translation, assessment strategies, treatment, and risk factors for chemotherapy-induced peripheral neuropathy. And co-presenting with her is Peter Grimison, a senior staff specialist in medical oncology at the Chris O'Brien Lifehouse in Sydney and a visiting medical officer at Royal Prince Alfred Hospital and a clinical associate professor at the University of Sydney. And Peter's clinical work focuses on testicular cancer, sarcoma, and upper GI cancers. He serves as a member of the Australian Government Pharmaceutical Benefits Advisory Committee and several other federal and New South Wales government committees. So welcome to Susanna and Peter. I look forward to hearing more about your work.
Thank you so much for inviting us here to speak today. We're really, I guess, at the opposite end of the spectrum to the work that Joanne just presented, because we've done a lot of work in chemotherapy-induced peripheral neuropathy, but we're really, I guess, at the beginning of our implementation journey. So it was fantastic to have that guidance from Joanne, and we've found all the resources from the ADAPT team to be extremely helpful in trying to think about how we can implement improved screening in chemotherapy-induced peripheral neuropathy. So just to give a brief background, chemotherapy-induced peripheral neuropathy is a prominent side effect of many chemotherapy treatments used for a variety of very common cancers, such as bowel, breast, ovarian, and blood cancers. We currently know that CIPN reduces tolerability of treatment, but it also produces long-term side effects. So There's currently no standardized method to identify which patients are more at risk of toxicity. And the way that this side effect is screened in clinics is currently very ad hoc and differs a lot between individual clinicians and between different hospital settings. Currently, there's no neuroprotective strategy, so no drug that can be taken to protect the nerves from lasting damage. And really the only strategy to prevent permanent disability is early reduction or cessation of the neurotoxic chemotherapy dose. I guess this underscores to us the critical importance of being able to implement improved screening procedures so that patients with early signs of neurotoxicity can be identified early, and that appropriate strategies such as dose reduction, obviously in consideration of other clinical factors, can be implemented. And so our team has been working on this area of research for quite a while, and we had a Cancer Institute New South Wales Translational Program grant, really bringing together a lot of different areas. So looking at this from both neurology and oncology perspectives, but also incorporating clinical trials, basic disease science, health economics, to try to look at this toxicity from multiple angles. And we have a large group of clinical and research partners. We've been implementing a large-scale study looking at what is the best way to assess this toxicity. And this is obviously a research study rather than an implementation study, because each assessment takes sort of an hour to an hour and a half to complete. And we do a whole range of different types of assessments. So looking at clinical severity, patient report of their neuropathy symptoms, quantifying their deficits in sensation, quantifying issues with fine motor skills and balance, and quantitative tests of nerve function. And so over this time, we've recruited a large cohort of patients to try to look at what are the risk factors for this condition. But obviously, this kind of intense research-based assessment is not going to be something that can be done routinely in clinical practice. And so we really wanted to look at, well, boiling this down, what is the best kind of tool that we can use to improve the screening in routine practice? And so we did a systematic review looking at different assessment tools for chemotherapy-induced peripheral neuropathy, and we found that there were a lot of them, and there really wasn't any consensus on the best tool. So we boiled these tools down and then did a Delphi of clinicians to try to form a consensus on what was the best available tool to assess neuropathy. There was no consensus on the overall best tool, but this did indicate some important issues. For example, only short patient-reported outcomes rated well for appropriate level of effort. So basically, that indicated to us that something that would be feasible for screening would need to be very short. A lot of the typical patient-reported outcomes that are used in research in this area are sort of 20 items, and that was felt to not be feasible for routine implementation. We actually had hypothesized that perhaps a composite measure, so including some brief patient-reported outcome and a more objective measure, in this case we used a tuning fork to quantify sensation or vibration sensation. But when we actually implemented this, we found that incorporating the vibration sensation didn't improve the outcomes compared to just standard patient-reported outcomes. So this, I guess, in a sense, was good news in that it let us know that if we could implement a very short patient-reported outcome measure, that would be a similar level of comparison, including objective outcome measures. So hopefully this will increase the feasibility of actually improving this in clinical practice. I guess that brings us on to our current project for how can we implement this improved screening routinely. And so we were very excited to be awarded a Sydney Health Partners Implementation Science grant to look at this project. We had a range of different collaborators, and I think this is also underscores something that's really been important in our program by able to combine different perspectives. So led by Peter and myself, the team included medical oncologists, included neurology academic researchers, nurses, consumer research partners, and allied health. And so the aims of our study to determine the feasibility of enhanced clinical screening for chemotherapy-induced peripheral neuropathy and to develop a clinical pathway for improved screening, assessment, and management. And so our screening pilot study is going to be running at Chris O'Brien Lifehouse, Royal Prince Alfred and Prince of Wales hospitals. And we will be using 3 brief patient-reported outcome screening tools in a prospective sample of 150 patients. And we're going to use this to assess the feasibility of using these kind of screening questionnaires in clinical practice, both from the clinical perspective and also from the patient perspective. And so we'll be focusing on patients treated with paclitaxel, oxaliplatin, or bortezomib, which are some of the chemotherapies that are associated with high rates of neurotoxicity. We'll be getting the patients to undertake the screening questionnaires prior to each chemotherapy cycle, and then assessing the feasibility of this approach. So at this stage, we're not trying to assess any outcomes in terms of the severity of their neuropathy, just the feasibility of actually doing this screening. And these are the screening tools that we're going to use. They range from 2 questions, I think, to 11 questions. And we decided to use multiple questionnaires just because it wasn't clear which one of these would perform best. So the second phase of this project is to develop a clinical pathway to try to guide if these screening questionnaires can identify patients that have significant neuropathy, what should be done next. And I think this is what we identified as a really big gap. In our previous studies, it's sometimes difficult to get uptake because there's not a treatment for chemotherapy-induced peripheral neuropathy. It's sometimes felt to be less important to screen and monitor. But obviously, we believe that identifying early signs of toxicity is extremely important in reducing the long-term burden of these symptoms. So providing a framework for what should be done next was seen to be really important amongst our clinical partners. And so we're aiming to pilot this, to develop and then pilot this clinical pathway in a small number of patients to sort of examine the feasibility of this pathway. So we've developed a draft pathway, which is shown here. And the next stage that we're currently starting is to do a Delphi survey of all of our stakeholders to try to identify the next step for this pathway, what other elements should be included, and to get consensus and agreement amongst our clinical partners. And obviously this includes oncologists, but other services such as neurology and allied health who might be involved in seeing these patients to ensure that the clinical pathway is something that stakeholders agree can be feasibly implemented. And so for this project, we've used the Medical Research Council framework for complex interventions. And so I guess we're at the feasibility and piloting stage. I hope this presentation has illustrated a lot of the work that we've done before getting to this point, not so much in implementation science, but in the broader field of understanding our stakeholders, understanding how we can work together, and understanding different methods of screening and assessment for this toxicity. So in terms of the outcomes that we're going to get from this project, for the feasibility, we'll be looking at the time taken for this screening, any identified problems, and the feasibility and acceptability through semi-structured interviews with clinical personnel. And from the patient side, we'll be looking at acceptability, ease of use, and feasibility. And for the clinical pathway, we'll be looking to develop consensus through that Delphi process on the steps in the clinical pathway, and then looking at a pilot implementation, just looking at feasibility, ease of use, and also, I guess, trying to identify those outcome measures for future work. So can we get information from the medical notes about the uptake rate of this pathway? Can we monitor, pathway fidelity and referral rates? And how is this actually going to work in practice in a larger clinical trial that will be done later on? So I think, obviously, the caveat being we are still at an early stage of this project. I think some of the key enablers that have got us to this point have been our existing collaborations over many years with clinicians who are really motivated in this area. And that's been a fantastic experience, and hopefully that will assist us in this project going forward. Having a research team with both clinical and research experience, I think, has also been important, as well as involving consumer research advocates at an early stage. And we've had our consumer research partners involved for sort of over 5 years now, which I think helps set the basis for, what sort of interventions are important for patients. In terms of barriers, and I think this has been noted before, we're running this at a couple of sites, and there are major differences in the medical notes systems. And so that means that it's difficult to use those systems across sites. And even in terms of the preference for how to do the screening across different sites, there are different preferences in terms of using iPad or mobile-based tools versus paper-based tools, and they differ based on the individuals at different sites. And also we have had some delays due to differences in research governance procedures across sites as well. And I think because of these delays, we have had some staff turnover in terms of identifying clinical champions, but then due to the longer time frame, we then need to identify other people. So I guess it just indicates that we need to have a large pool of people who are really engaged in the project going forward. And so I think we'd like to thank Sydney Health Partners for giving us this pilot funding to undertake this work, and all the investigators on the project, as well as in the larger team. And I think Peter now is going to add some of his thoughts on this from a clinical perspective.
Thanks very much, Susanna. So Ben, I'll stick to 2 or 3 minutes to keep us on time, if that's okay. So I think Susanna presented that really well, and I think it really complemented Joanne's presentation as well. Obviously, we're at a different phase, but lots of overlapping issues, and I've been involved in both projects. I just wanted to bring out a little bit more about the champions and thinking about how you can make your implementation study successful. And I think you really need to think about what's in it for the stakeholders, how they will benefit. And certainly for this study that Susanna's just presented, the patients are really engaged. Susanna's correct, we don't have treatment for this condition, but I even saw a patient today who's very concerned and debilitated by their neuropathy, and just the idea that someone's got to take an interest in that and learn from that with the thought it will help the next group of patients is really helpful. So if the patients are motivated, that will help. Other things, what's in it for the site, something that appealed to me about being involved in this study is that we can better systematize doing this routine collection of patient data. And I'd actually like us to use an electronic method where patients go on their mobile phone, it goes automatically into our electronic medical records. So being involved in the project will not only help Susanna's group and let us do routine screening, but it will actually change the way we do things at the institution where I work with this electronic data capture, which will help across a whole range of research and routine clinical issues as well. And we've got the IT department, we've got the executive involved, and having that extra involvement and motivation will help. The final comment, champions are really important. I've spoken to the nurses who are going to actually be doing this work, and some of them love the technology, some of them don't, some are interested in this condition, some are not, but it's often a champion at the site will need to draw out the other staff involved. And if they're on site, it will be successful. But if those other people who are going to be doing the grunt work, this applies to Joanne's study as well, if those people are not engaged, then often it tapers off. So having champions who will liaise with the research implementers and the people on the ground is important. The final comment about ethics and governance, Susanna mentioned this study. In a sense, it's a very simple study, very low risk to patients, but the ethics and governance has been very complicated. And I think it's good when you're implementing studies at sites to have a good relationship with the ethics department and the research governance at each site, and trying to explain what's being tested here. So if routine screening is part of clinical practice, then that's not the research, and you don't need necessarily need individual consent from each patient, but what is being tested is the process of implementation, and in a sense it's the staff are being researched to see how well they can implement the project. So having those conversations with ethics and governance can make things easier. And I think the irony is that if tomorrow an institution decides to implement a new treatment without evaluating it by research, then you can do that without any ethics or governance, no consent forms, no protocol. But if you want to do it the right way and implement it with evaluation, then it adds a lot of complexity. So really good implementation does get penalised. But as I said, good relationships with the ethics and governance staff can help. So thanks, Ben. That was an extra minute, sorry.
No worries. Thanks for those thoughts, Peter, and for a great presentation, Susanna. Yeah, I can attest to, I guess, the unfamiliarity of some ethics committees with implementation research and the challenges that can create. But as you say, I think open communication with them about that can certainly be helpful. There's a couple of questions that have come through. I just have one burning question that's kind of been sitting in my mind since Joanne's presentation. Like, something that came up in both of your projects has been, I guess, adaptability and adapting things for different contexts. So I'm just wondering, with your draft clinical pathway, whether you have some kind of process in place for identifying what the core components of that pathway are and which bits can be kind of tailored according to implementation at different sites.
Yeah, I think obviously we've still got the consultation process, so perhaps, some things will come to light in that of how we can better tailor it. We've tried to leave it, so rather than being prescriptive, we tried to sort of leave it a bit open. In some of the things that we're suggesting are when you might refer patients onto other services, but obviously what other services are readily available, will be very variable across different settings. So we've sort of tried to provide multiple options based on that, but also leave it a bit open. So this is when you might want to consider this approach, but being more prescriptive about the type of screening that we think can be implemented at any kind of center.
You've obviously got a quite a broad and diverse team, but someone, Marie March, has asked, is there, or did you consult with podiatrists at any stage at all? And is there a way of, I guess, bringing in people who might not normally be embedded in cancer pathways, but can offer some kind of specialist expertise in a particular issue?
Absolutely, yeah. We haven't specifically, but I think there's really a broad range of, I guess, circles of people that might be involved. So we are keen to sort of get widespread uptake. And again, I guess it also depends on people that have a particular interest in taking this forward. We do have a lot of allied health involvement as well in our research team, because physiotherapists, exercise physiologists, occupational therapists do get referred these patients, particularly usually at the pointy end when they have significant problems. And I guess one of the points of the pathway is if we can intervene at an earlier stage to promote those referrals. I mean, and I guess one of the points about not making the pathway be prescriptive, that there's a range of issues that patients can have and secondary issues from neuropathy. So, there may be people that have a lot of prominent issues with their feet, which would, immediately warrant referral to someone like a podiatrist, whereas other patients may have more issues with, walking or gait or other aspects of their function. So I guess it's really highlighting what can be done, but then, of course, leaving it open for what the individual would need.
And Ben, just to quickly follow on from that, a number of our other staff at my institution are very interested in using the data from this screening to identify patients for potential studies. Susanna's helping to lead a study using exercise physiologists to treat patients. We've also got someone in acupuncture very interested. So I think there's opportunity through these implementation projects to draw in other practitioners who may be or should be interested in research.
Yeah, no, that's great. There's an interesting comment from Elizabeth Pearson here, Peter, who says she often has difficulty convincing oncologists about, I guess, the merits of the strategies being investigated in these kind of implementation studies, and because they often come from a more like, randomized controlled trial kind of very orientation where everything's very tightly controlled. Any tips for Elizabeth about how you convince clinicians of the merits of this kind of work versus doing RCTs?
I think it's about what we were saying before about thinking what's in it for them, or what's in it for the patients, or identifying other champions within the unit. And for example, with this particular study, actually getting the nurses on board was better, and we've actually got some senior nurses who've got capability to lead that research. So that's one strategy. Or with Joanne's psychology study, having the psychologists as the lead's important. But also, I think if you can get patients who are saying this is a problem, or you can actually go to executive and say the Cancer Institute New South Wales mandate routine screening for this condition or that condition, or routine treatment of a particular thing. And if executive notice that the institution is underperforming, then maybe that's a way to convince the other stakeholders or clinicians that it's important and worthwhile. But I take your point. The garden variety clinicians often want to do randomised trials of treatment, so you try to find a champion elsewhere.
All right, thanks. And I think Joe might want to add a comment as well.
Yes, just sort of backing up what Peter was saying, but also what we've found is that often the influencers within in services may not be the people that you think. So you think that you have to engage the oncologist, but it actually may be a nurse, one of the senior nurses on the ward, or it could be different disciplines who actually influence the culture and the likelihood of a service or a clinic participating in research. So I think it's also thinking about thinking outside of the box and looking at who actually is this going to impact the most, and getting them engaged, because then they can influence the reluctant, and I'm oncologist, sorry to bash the oncologist in the room, but the less engaged disciplines.
And one final question, Susanna and Peter, are there, for the healthcare practitioners who might be less knowledgeable or engaged with the screening process, is there any plans to include some kind of educational training component in your work to try and, as one of the strategies, I guess, to improve the application of screening?
Yeah, I think that is definitely important. And there in the pathway, there's also sort of education resources as well. I guess one of the other things is that although the familiarity with the optimal screening may vary, but this kind of screening is a part of routine care already. So, obviously the clinicians that prescribe these neurotoxic chemotherapies know that this is a side effect, and everyone has their own way of, how they incorporate that in their program. So I guess it's kind of harnessing that fact, and then how to leverage it to make it more standardized, so that everyone is doing it the same way and involving the patients in the same way.
But Susanna presented at our Journal Club research meeting, and there were a really engaged group of clinicians, including senior and junior clinicians and nurses. And I think that was a really good way to remind of the clinical relevance. I think Cassandra was putting up her hand, sorry.
Yeah, I think Steve Ackland might have a comment. He's sitting with Cassie.
Thanks for allowing me to talk, Ben, and hello everyone. I came in late, so I might have missed some of this, so it might be irrelevant. One of the issues for clinicians is that the definition of peripheral neuropathy is very vague, subjective, and only when it's late is it objective, and therefore very difficult to evaluate in any quantitative way. Now, there's a recently, I think, published now paper from a Japanese group, which I would call the paperclip test, where they time how long it takes for a person to pick up a paperclip one at a time off a table and put it on a piece of paper within a boundary. And it's how long does it take you to do that 5 times? It's validated by this Japanese group, and it's a very easy quantitative test for aspects of peripheral neuropathy. You might want to have a look for it, Susanna.
Sure, you know, I've read that one. And there's also the 6-button test where you do 6 buttons on a shirt. I think with something like peripheral neuropathy, that a lot of the symptoms are not evident, so it relies on patient report. There are objective tests you can do. I guess the difficulty with some of those is the variability in the condition. For example, a lot of people have very prominent symptoms in the feet, and obviously the paperclip test, you know, would not be able to pick that up. So I think that's why, although obviously, you know, there are issues with patient-reported outcomes in terms of objectivity and you know, being able to quantify the level. In terms of clinical screening, I guess at the coalface, it seems that patient-reported symptom questionnaires are the best. They do actually typically pick up signs of neuropathy substantially earlier than other tests. For example, even to have a deficit on that paperclip test, you'd have to have some substantial numbness, and that typically will come after the patient is already aware of the symptoms. So for that reason, at least for screening, but obviously in terms of quantifying neuropathy, you know, in a trial setting, there are lots of other outcome measures that we can use that I guess might be less appropriate for routine clinical screening.
Good.
I guess it just shows, yeah, the different applicability of measures in research and practice, and you know, that sounds like you've given a lot of consideration to that, Susanna. So we'll wrap things up there now, but thanks again to Susanna and Peter for another great example of a project that is looking to trial some implementation or look at feasibility and implementation of a particular practice. We'll now hand over to Dr. Cassie White, who's a medical oncology clinical trials fellow at the Central Coast Cancer Centre and a PhD student at the University of Newcastle. She's undertaking a project exploring the use of DPYD genotyping for DPD, which is I'm sure I'm going to mispronounce this, but dihydropyrimidine dehydrogenase enzyme deficiency. And Cassie's assessing the feasibility and clinical application of DPYD genotyping for patients, and after implementation, reviewing the clinical effectiveness and cost effectiveness of the strategy. And we first heard about Cassie's great project when she presented at one of our concept development workshops last year. We're really delighted that she can share that work more broadly today. Thanks, Cassie.
Thanks, Ben. Thank you so much for allowing me to present today. As you said, I presented this as a concept development in a workshop back in December last year to a panel of implementation science experts. And the feedback that I got was incredibly helpful and really stimulating, and has helped me sort of progress forward with this study. And so I guess I'm coming from a clinician point of view and trying to sort of help other clinicians to consider implementation science as part of their concept developments. Okay, so just some background. So fluoropyrimidine chemotherapy is a very common type of chemotherapy which is utilised across various different tumour streams. And there's over 10,000 patients per year in Australia who receive fluoropyrimidines as part of curative and palliative chemotherapy regimens. Up to 30% of patients develop serious toxicity, and there's an associated 1% fatality from toxicity. So DPD, dihydropyrimidine dehydrogenase, is the critical enzyme that's responsible for fluoropyrimidine metabolism and excretion. And a deficiency in this enzyme leads to a buildup of chemotherapy and increased toxicity. DPD is controlled for by the DPYD gene, and there's many, many different variants that have been found over the last sort of 20 years pertaining to the DPYD gene, but 4 main variants that have been found to cause significant chemotherapy toxicity. And they're present in approximately 8% of Caucasian populations. Historically, they haven't really been identified until after patients have been exposed to the chemotherapy and developed the serious toxicity, and then retrospectively tested for DPYD variants. And so recently there's been a push for some pre-treatment screening for DPD deficiency and associated DPYD gene variants, and that's being pushed out in the Netherlands, the UK and the France as of 2020. And this is following some data that illustrates that prospective dose reduction in gene variant carriers leads to safer chemotherapy delivery and less toxicity for these people. And additionally, some retrospective analyses have suggested that there's some cost effectiveness associated with upfront genotype guided dose adjustments. And so the focus of our pilot study is trying to evaluate the feasibility of instituting a pre-treatment screening program in Australia. And we're aiming to really explore the barriers and enablers associated with offering this type of service, a service of this nature in Australia. And we're using this feasibility study as a platform to develop a larger scale program. So in a nutshell, I think our project is quite a nice example of a hybrid effectiveness implementation model. Because we're incorporating a simultaneous analysis of the clinical and the implementation science objectives. And the reason that we're trying to do this is because we want to create not just a successful, but a sustainable clinical intervention. And so patients who are eligible provide a blood sample at the same time as they have their standard pre-treatment blood tests. And the genotyping is conducted here at John Hunter Hospital in Newcastle, and it's a simple PCR test. Those results go back to the treating oncologist for a decision regarding chemotherapy dosing. And at this stage, it's completely physician discretion as to what they want to do with the dosing. We're available for any support and to guide them toward the international guidelines, depending on what type of variants are found. And our primary clinical endpoint for this pilot study is the feasibility of the testing turnaround time. And so from the implementation science point of view, our implementation evaluation takes the form of stakeholder questionnaires. And so these are a combination of direct questions, attitudinal scale questions, and some free text. We've kind of got 2 cohorts of people. So we've got healthcare providers who are those stakeholders who are identified to have the most contact with patients while they're having their toxicity. So oncologists and oncology trainees, oncology pharmacists and nurses. And so there's an initial questionnaire to healthcare providers prior to patient recruitment, which just tries to estimate the pre-existing fluoropyrimidine toxicity incidence and to really gauge awareness and understanding of DPYD testing, and to try and estimate the time that healthcare providers are prepared to wait for the turnaround of results. And there's some free text areas for these people to provide comments on their preconceived ideas of enablers and barriers toward this kind of intervention. Our follow-up questionnaire is being circulated after patients are being recruited, and we're having some testing results coming through to try and gauge the degree of interaction with the test and the satisfaction of the healthcare provider with the service that we're offering. As I mentioned, the patients are also evaluated, and they're surveyed only once after they've undertaken the testing and started their chemotherapy. And the focus is really on what kind of education they received from their healthcare provider, whether they have any recollection of taking the test, whether the results were discussed with them, and whether they noticed any treatment changes in relation to the results. And all stakeholders are going to be asked for an estimate regarding the cost of the test, as this is not a Medicare funded test at present, and we really want to try and gauge the affordability and the worth of testing for patients and healthcare providers alike. And so our implementation objectives are identifying the stakeholders and predicting behaviours and attitudes towards testing, identifying the barriers and enablers toward implementation, and trying to apply the lessons that we learned from this pilot study toward a larger scale collaboration program. And we want to implement strategies that are going to help us to overcome the barriers and to enhance the enablers that we identify along the way. There is some precedent for incorporating implementation science within genotype testing that's come from Martin and colleagues in the Netherlands. The enablers and barriers that they've identified, we expect some of them to overlap with the outcomes in our study, but we also want to see if there's any sort of more unique factors that pop up that are particular to the Australian healthcare system that we need to look into. We've chosen to use the theoretical domains framework as our method of evaluation for this phase of the feasibility study. And we expect that the domains that will influence our stakeholders' attitudes and behaviours should be modifiable with the right interventions. So things like education, clear guidelines for action, promotion of the service, those kinds of things. And we really want to try and utilise the data that we gather from the pilot study to help to direct us on how to engage stakeholders and to really manage our resources and our funding for maximal success and sustainability of a larger scale clinical intervention. And so this is just an overview of our proposed larger scale program. So we're currently collaborating with Peter McCallum down in Victoria and some sites in Sydney. We're hoping to be able to invite other states and territories pending what funding and infrastructure we can offer within the trial. We're aiming for at least 1,000 patients, probably more. And this will be the first pharmacogenomics program within medical oncology in Australia, as far as we're aware. Our objectives are going to be spread across clinical, implementation science and health economics domains. Plus, we also want to have a discovery science component where we'll explore further genetic and genomic factors that are associated not only with DPYD variants, but with DPD deficiency in general and fluoropyrimidine toxicity. And we'll gain some of the samples for testing from this program. And the focus of the implementation science within the larger scale program will shift to include an analysis of the evaluation measures. It will help to sort of analyse what strategies we've implemented already and the effect that they're going to have on a larger scale, and to help us to create sort of sustainable strategies to continue successful implementation into the future. And we hope to incorporate a little bit more qualitative analysis in our larger scale program. We're still discussing what the optimal option for implementation science tools will be for the larger scale program. So watch this space. So thank you very much for allowing me the chance to present today. And I really highly recommend any clinicians who are trying to develop a concept to take part in the concept development workshops. They were really worthwhile.
Thanks so much, Cassie, for a great outline of your project that you're currently undertaking and future plans. Just a reminder for people to use the Q&A for the questions. While people are thinking, I just suppose I have one question. I mean, we have really tried to tailor this webinar for clinicians who might be interested in undertaking some feasibility implementation studies. So, Cassie, do you have any recommendations as someone doing their first study of that kind? What are the, I guess, kind of key learnings for you, or things you wish you had known, a year ago when you first started?
I'm learning as I go. This is all new to me, and I'm very much still a novice. I was even more of a novice before the concept development workshop. I think that was an incredibly useful tool to have at my disposal, and really being able to hone in one-on-one with a panel of experts and talk through my study and get feedback that was sort of tailored to what I was trying to do. That was a really, really, really helpful exercise for me. Yeah, it's a work in progress, and I'm learning as I go.
No worries. Someone, Ayano Kelly's asked, got a question about how you're integrating health economics into your kind of to further implementation work, asking how you plan to use a discrete choice experiment to further your implementation objectives.
Yeah, so we're working with a health economist. We have only a very sort of skeleton outline of how that's going to look at the moment. But yeah, we are planning on incorporating some discrete choice experiments in our larger scale program and looking to try and evaluate what factors are important to stakeholders and what the trade-off or what the cost that they're willing to sacrifice and what they're hoping to gain through a discrete choice experiment will be. So we need to workshop that a little bit more, but that will be something that will be built into the larger scale program rather than our feasibility study.
Yeah, okay. And you mentioned some of the questions that were included in your survey of healthcare providers involved in delivering this test, and often, I guess, for acceptability and feasibility studies, those questions are purpose designed. But can you tell us a bit more about the process that you kind of went through to decide what to ask, who to ask it, and whether there are any kind of guidelines or things that you found useful to make those decisions?
Yeah, so I guess the reason that we chose to do questionnaires in the first place is just because it offered a nice sort of amount of quantitative data that will be relatively easy for us to analyse within the budget of the feasibility study and within the time constraints that we have.
Mm-hmm.
There's a little bit of scope for some qualitative data in there as well, some free text areas where people can really, if they're passionate about an enabler or a barrier, they can elaborate a little bit further. And we've tried to offer a little section where they can provide contact details where we can call them and talk about that in more detail if it's something that needs further exploring.
Yeah.
In terms of actually formulating the questionnaires themselves, there was a lot of discussion between myself and my supervisors. Thankfully, I've got a wide array of supervisors from sort of clinically based oncologists and clinical researchers to cancer implementation and behavioural scientists to molecular geneticists. So we talked a lot amongst ourselves and tried to work out what was pertinent to what we're trying to find out about the study and how we're going to help to integrate the clinical intervention into clinical practice. And then came up with a list of questions that workshopped again with one of my supervisors to see if they were sort of on the right track and whether I was asking the right question to get the data that I need to then move on to an analysis at the other end, which again was something that was new for me, sort of trying to hone down the language and really target the questioning so that I had data that was usable at the other end rather than just asking a blanket question that could have given me a really wide array of data.
Yeah. Okay. I think those are some great tips. Engaging broadly and like piloting it before you roll it out. Another question here from a clinician researcher, Dr. Maria Mateus, who works in pharmacogenomics in pediatric cancer, says, interesting study, great work, Cassie. Wonder if you've considered the infrastructure required for return of results. Will there be a MTB or multidisciplinary team to review the results as part of looking at the feasibility and sustainability?
Not at this stage. The reason being is that the genetic testing that we're doing is quite targeted. So we're predetermining the variants that we're looking for, and so we know that if patients return with a variant that we've looked for, we know or we can predict the clinical implications of that. So we haven't opened it up to MDT discussion because we are just doing targeted testing. But I guess for future discovery science, as we move away from individual SNP testing toward perhaps more sort of whole exome sequencing or whole genome sequencing, there will be more of a scope to liaise with other specialists to try and determine if a patient does return multiple variants, what they mean and what the clinical implications will be for that individual patient moving forward.
Right. Okay, sounds like you've given it a lot of thought. We might now open it up for a more general discussion, but thanks to Dr. Cassie White for a great insight into what it's like to do your first, I guess, feasibility implementation trial. And so if everyone wants to turn on their cameras, we'll now have a more general discussion, get back to some of the questions that we missed initially. But if anybody has new questions, feel free to add them to the Q&A. I'll start with one from Kirby Stewart, who asks, do you think there's a place for a structured change management approach to support implementation strategies? I don't know, which almost seems to be an implementation strategy in itself, but perhaps Joe, you'd like to comment?
Yes, thanks for the question. I think that one of the issues with a structured change management strategy is that change management within the health service has a really bad reputation. It tends to be top down. There's little consultation. And so I think implementation strategies are by definition change management, but I think that you just need to be a little bit careful about how you position those changes. What you want to do is you want to use the context, the local context and the evidence, and have really clear facilitation to change practice rather than having a structured plan that is typical for change management. You know, and make sure that you've actually you've got engagement and bringing people along rather than imposing a change.
Good points. Any other comments on that from other people working in healthcare services? Okay. All right. Well, I've got another one that I'm going to paraphrase from Lauren Winkler. And I guess it's more about, it's a bit about how do you decide if you get to the end of a feasibility implementation trial and things don't work out as planned, how do you decide whether to proceed or not? I mean, I'd be interested to hear, I don't know if it was touched on too much, but what the kind of progression criteria were in the different studies that have been presented. Was there a scenario where you would have gone, okay, clearly this isn't going to work, you know, we need to go back to the drawing board or yeah, try something completely different? So any thoughts on how you decide whether to proceed versus make modifications and yeah, those kind of decisions? Susanna, do you have any in your study? Do you have kind of criteria, feasibility criteria that need to be met to kind of keep going?
I think it's sort of an iterative process. So we haven't got set criteria that would define, I guess, success or failure. But I suppose also because when you're working at different sites, it's hard to anticipate the different things which might happen and which would have more bearing on if it would be successful. So I guess, yeah, I think it's just evaluating that with a broad group of people from across, you know, the people who are actually doing the work. So the clinicians, the nurses, the relevant team to make those decisions.
Ben, I don't know if you want to speak to a study you designed relating to your PhD about a online treatment for testes cancer, and it's related, but actually a reverse situation where Ben led the development of a really good online tool for testes cancer survivors for treatment of anxiety and depression, and the preliminary piloting showed there was engagement and use. And the question was whether it would be worthwhile to do a large randomized trial. And it was actually felt the feasibility of doing the trial would be difficult, but based on the level of engagement by the participants and the preliminary data, that was actually worth rolling it out in the absence of a randomized trial proving benefit. Ben, do you want to, I know it's a slightly different question, but did you want to comment further on that from your experience?
Yeah, I guess it does highlight that some of what Susanna said, that sometimes it doesn't necessarily make sense to pre-specify criteria, but I think you do need to, at the end of these kind of trials, yeah, think about what the next stage might look like, and you shouldn't always assume that, yeah, the next logical step is a, you know, large randomized control trial, or if you're trialing implementation strategies, it might be a cluster randomized control trial. So there might be a more pragmatic trial design, for instance, that you can take, or you could implement it, assuming there was no evidence of harm, for instance, and some preliminary benefit. You could potentially implement and collect data in a more real world environment, rather than trying to, which is never going to be able to tell you, is it specifically the intervention versus something else that's having or delivering the benefit, but can still answer some other important questions. So important to, I guess, consider or keep other options on the table.
So, example where you would not want to do that, a treatment that was very costly, that had a lot of side effects, very difficult to implement, but the rest of that, one that's cheap, minimal or no expected side effects, easy to implement, has good face validity, good level of, engagement and use, you can make a judgment as to how rigorously you need to evaluate it.
Yeah, very intervention specific, I think. Jo, did you?
I was just thinking, and I agree totally with what Peter was saying, but I think it really comes back to what's the purpose of an implementation study, a feasibility study, and it is actually to ascertain whether or not you can do it. And so if at the end of the feasibility study, your determination is, no, it's not feasible to do, then that's when you have to have a really hard look at what you're planning, because there's no point developing interventions and trying to roll out interventions if they just are not feasible in routine care. So, I think that's one of the good things about working in big collaborations, is that you can all discuss and weigh up, was it the design, can you actually salvage it, or is it really a hard decision to say, great idea, just not feasible?
Yeah, very, very good points. Cassie, do you have anything you'd like to add to that?
No, not really. I guess looking at our own study, our feasibility outcomes are very simple. So looking just at turnaround time. So I guess by keeping your objectives quite simple, you can get a good understanding of whether it's going to be feasible without sort of expending too much time and funding on it in the initial stages. And then that hopefully should give you enough information as whether or not to pursue it on a larger scale.
Mm-hmm.
So Ben, we've made a pragmatic decision that we do need to do a larger study because our ultimate aim is to get a Medicare benefit schedule item for DPYD genotyping in this context, and that will overcome some of the willingness to pay issues by clinical services or by patients, which is part of the things that we're asking in questionnaires, willingness to pay. So that's really the fundamental reason why we think a larger clinical trial after this feasibility study is done is necessary. Frankly, and we could be quite wrong here, my view is that the clinicians want this. When the patients hear about it, they'll say, it's a no-brainer, take my blood now, and let's just get on with it. But I think we do have to establish that it's cost effective in order to get health administrators to believe that it's worthwhile, and in order to mount a good enough business case for a Medicare benefits schedule item.
I think you raise a really good point there, Stephen. It's probably something worth keeping in mind for anyone doing pilot or feasibility implementation trials, is to, because this health economic data is becoming so important, to consider as part of your feasibility study, you might look at how easy you can access the data you need to do those kind of evaluations. Well, I think we're just about out of time now, so I might just wrap up by thanking all our fantastic presenters, Associate Professor Joanne Shaw, Associate Professor Susanna Park, Associate Professor Peter Grimison, and Dr. Cassie White for sharing their expertise and experience with us all. I hope everyone who's joined has benefited from that. I thank you for all of your questions, and just letting everyone know there'll be a brief 5-minute post-webinar survey that's sent to everybody at the conclusion of this webinar. And I'd also like to thank Stella Boo, who's the incredibly clever and well-organised implementation science community practice coordinator, who works really hard behind the scenes to pull all these events together. And also, it's been a pleasure working with the Sydney Health Partners Implementation Science Community of Practice on this particular event. And thanks to Helen Hughes in particular and Nicole Rankin for their help developing and promoting the event. And yeah, so thanks everybody. And if you do want to learn more about this area or be involved in more of these events in the future, we'd encourage you to look at the websites listed here, and we will be posting a recording of this webinar on the Cancer Implementation Science website next week sometime. So thanks everybody again to all our wonderful presenters and participants. Really appreciate everybody's input. Yeah, great. Thank you, and have a lovely weekend.